Right, so it's a combination of somatic and, what's the other, somatic and visceral all called something. I'm blanking. Nociceptive, right. It's nociceptive pain and neuropathic pain together. So when you have low back pain, it involves both, right? If you have migraine, it involves both. I don't know, so low back pain makes more sense to me than migraine, but that's what mixed pain means. Which really means you're gonna actually treat both sides of that pain pathway. You're gonna treat nociceptive pain, which is the bone and the joint and the muscle pain, but you also have to treat the nerve pain when it's mixed pain. That's a good question. Yeah.
So for in general with all the drugs, should we know like a couple of the main complications or side effects with those drugs, or is that going to be less tested, more of which one would you use for this?
Probably more like which would you anticipate using. So for the first module dealing with all of the pain things, I pulled those off of the protocol. So when you look at your pain protocol, you'll see if the patient has nausea, you use this one first. Then if it's not resolved, you use this one next, right? So be familiar with reading and understanding the protocol, how you would do that in that order, right? So if I asked you like, oh, you've given the patient aldosterone and it's not relieved, what medication would you anticipate giving? Right? You'll look and it'll be like the next one down on the protocol list, something like that, right? If it's for itching, though, you're gonna look and it's gonna say give Benadryl for itching, right? So I wanna test if you know how to basically read a protocol. You have lots of protocols in clinical, right? Like you have to look through and they come up on your electronic charting. Mechanism of action or what it exactly treats, not so much. But like when we get into like urinary tract infections, some of those require antibiotics. Some require, and know the classification, like antibiotics versus ones that are just antispasmodics, and then there was a third one and it was it's the one that numbs the urinary tract, but I can't think of the classification. Analgesic, yes. The urinary analgesic, yes, thank you. That's the third one. Hannah, did you have a question?
Yes.
Yes.
For the seizures, is like the benzos like first one that you did instead? I'm confused. Like, what do you do with that over
Right.
benzos?
So there's maintenance medications for someone diagnosed with epilepsy. So those would be more like oral medications that they would take. Dilantin can be given, those sorts of things are derivatives of that. In a hospital setting, when someone's having an acute seizure, the benzodiazepine is the classification of medication that will stop that seizure. So Dilantin takes too long. Ativan and Valium are faster acting, so that's what you're going to give in an emergent situation.
So like status epilepticus?
Yes, if your seizure's lasting a long time. In fact, sometimes benzos are just ordered for if a patient starts a seizure in the hospital, you're going to give PRN, Ativan, or Valium, whatever's ordered for your patient, right? Then if we're seeing a pattern of increase, then they'll probably have a scheduled order of Dilantin IV or something to prevent a seizure from happening, but to stop the seizure, the classification is benzos. Yeah, people aren't on Ativan and Valium PRN for seizures, if that makes sense. We use it in emergent situations. Like as a maintenance. So we're not giving them Ativan to prevent seizures from happening. We use it to stop a seizure. But yeah, Mina.
So on the blueprint, it says for the mobility section to look at like, assessment diagnosis for those three listed, the fracture and others. How in depth though do we need to know this complications chart that you provided?
Right. So what is a complication of immobility? What can happen? Most of those in the middle column should be pretty much a review, like a complication of the respiratory atelectasis, right? So be familiar with the nursing interventions that would prevent complications from immobility. A lot of them overlap, so that's easy to remember. It's not a memorization thing. A lot of them should be common sense when you get to a question about how am I gonna prevent complications from immobility. And if you kind of have read through that a few times, I feel comfortable you should be able to answer it. If that makes sense. Okay. But I would, yeah, definitely review that chart.
Do we know the types of fractures?
No.
Do we
If you
know?
get into trauma and stuff like that, you'll have a chance to get into all that, but yeah.
Do we need to know how to care for those different fractures?
Not the different fractures, it's just really how they're surgically repaired. So if I have like a closed reduction with no surgery, and it's just the cast or the immobilizer, I'm gonna care for that. I still have to know there's a broken bone here with an immobilizer, so I need to do the neurovascular assessment of that extremity, right? If it's an open reduction, internal fixation, I have a surgery with a wound, so I have to monitor that wound. If I have a external fixation, well, now I have pins into that bone, higher risk for infection, and I need to be able to assess that. So if you're really comfortable with those 7 Ps, and you know what normal would be, right? They should have a pulse, they should have warmth, right? They should have movement. All of those would be normal findings. Then you'll know what abnormal would look like. I want you to be able to tell the difference between what's abnormal and normal for 7 Ps. Yeah. Did that answer your question, Jose? Okay. I felt like I started talking a lot, and then I'm like, wait, what was the question?
Kind of along with that, so I have in my notes that for external fixation, you can expect the serous anguinous drainage. Are there any of the others that we should know and expect drainage? Because that's the only one I had it listed.
Any surgical incision, and you'll talk about this on your last lecture in this class, post-op, like after you've had surgery, like to have a little bit of oozing of serous or even a little blood mixed with that serous fluid would be normal. Even within the first few hours, even if you have red bloody drainage, that's okay. Where we get concerned is with infection. So no, I'm trying to think, I'm not assessing whether you know how much is too much blood, right? The complication with that type of surgery is when are they gonna have infection? So then you get that yucky drainage, right? Sometimes it's like purulent or yellowish or greenish, right? So remember that picture that I had of that external fixator, there's a lot of dressing wrapped around those often. And so we still need to take a little peek at those pin sites because that's a direct connection to the patient's bone, and we don't want an infection into that patient's bone while it's healing. So it just like any signs and symptoms of infection, fever, white blood cell going up, tachycardia, those sorts of things would indicate that there's a complication and infection probably happening. Did that answer it okay?
Yeah.
So going from the top, I just want to remind you, one good way to study would be to take the learning objective and make sure you can differentiate between the types of anemia. So use the table, right? When you're studying nursing process, write the nursing process out. Assessment, diagnosis, treatment, pharm, and education and evaluation. Can I speak to each of those on some level? Challenge each other, like name 2 assessment findings. Name 2 things that would diagnose this. Name 2 pharm things we talked about in lecture. Right? Name 2, maybe 2, whatever, patient education things related to that, right? So that would be a good way to just march that down. For the anemia, we have the table and then the Jeopardy. So use that if you want, the Jeopardy questions, just to help quiz you, okay? Then on the pain, we had the pain case study and the quiz. So I've opened the quizzes, so go back and look at that. In case you missed any on there. So if you haven't been looking at quizzes for review for exams, this would probably be a good exam to go back and look at those again. Okay. And then make sure you're familiar with the med terminology, labs, and meds I put on here are things you will come across, remember, but doesn't mean it's the answer. It's going to help you decide which one is the right answer. So if you're comfortable with all of those med terms, labs, and medications, you should be able to pick out which one the question's asking. And then the next, module 11, talking about seizures, remember there was a guided video, there was a video with guided notes. So if you haven't completed that, make sure you go back and use that to study. Talked about the types of seizures and, right? And then, we did the seizure case study with Sarah, who's a college student who stops her meds. Yeah. So there's some good patient teaching on that case study. Then the multiple sclerosis, ALS, and Guillain-Barré, we did the table together. So make sure you review that table. If anything on the table, you're like, I don't know what this was, go to your reading, right? Use that table as a launching point to go back to the reading pages and review that information. Because that's just kind of like cliff notes. The table's really like cliff notes. So, okay.
Also, in the nurses case studies book that we have, there is some ones for intracranial regulation, elimination, and something else. So
Is it the Nurse Tim, the case study
yeah,
book?
it's the big case study book that is
Yeah.
on our list.
If you feel comfortable with the information and you want a deep dive, otherwise I've read through those in preparation of what are we gonna assign to whatever, and it may go a little deeper than you need, so I don't wanna derail you, that's fine, but if you want, if I wanna study something but I'm done with my notes, I need to look at something else, utilize that as a resource, but otherwise I wouldn't spend too much time on those, just because I'm not gonna pull information from those, if that makes sense, yeah. They're a good resource. I think there are people in here who are just barely doing what they can do, and to add another resource would be like over the top, right? Like I have enough resources for you guys. So you have, okay, guided reading notes and seizures, that's for seizures, and then you have the table for MS, ALS, and Guillain-Barré. You also have a quiz and a Kahoot on that module 11. So review that one again too. Remember, Kahoot's just like Quizlet, it's just knowledge based. You have to be able to apply the information. So when you're going through it, ask yourself why. Why? Challenge somebody else, like, why is this the answer? Module 12, with fractures and amputations, the complication table, which we already talked about, that Nina brought up, plus PowerPoints and, for urinary tract infection, we did the system disorder sheets, those 2 system disorder sheets, and there's a quiz, UTI quiz, so go back and look at those. That one has some rationales on it too that might help you understand why you missed those. And then for the urolithiasis and BPH, erectile dysfunction, you talked about today, you did a case study. So be familiar with this stuff on the case study, the meds. I wrote down a lot of what I want you to know down there, so. If you don't know what a KUB, PSA, TERP, or CBI is, look it up in your reading, because you should know what that is now after Professor Bowen talked to you about that today. What else? Metrology, I like a good rate mil per hour. So if I ask you what the rate of the pump is, read the stem. I'm even gonna tell you mil per hour. It's gonna say mil per hour in there. Calculate to the mils per hour, right? What would you calculate the pump to? And then I like assessing your knowledge on drawing something out of a syringe, right? So be comfortable with those formulas, those 2 formulas. What else? If you think that taking the Foundations ACI will help you with test taking strategies, you can do that. Practice assessment. If you feel like that's gonna be too much for you right now, that's fine. You can take those practice assessments after Wednesday, or there's one practice assessment B after Wednesday. Remember, I want you to fill out that journal, that reflection, 10 questions, and I want that in the Dropbox before we meet